Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Joining me today is Dr. John Kelly, Elizabeth R. Spallon, Professor of Psychiatry, Harvard Medical School. He's also Director of MGH Recovery Research Institute, Director of National Center on Youth Prevention, Treatment, and Recovery, and President, American Board of Addiction Psychology. John, welcome.
Charles, great to be here. Thanks for having me.
Oh, thanks so much for joining me. FYI, don't necessarily have to take our listeners backstage, but we're recording this 7 a.m. on a Friday. So we're bright-eyed and bushy-tailed for this
That's
conversation.
Right.
Yes, did I miss anything in that intro, John?
No. That's good. That about covers it, I think. Yeah.
We first spoke last week about what we were going to talk about. You mentioned just sort of taking our listeners on a survey, last 50 years, war on drugs. Maybe we should start by asking, how did the 70s war on drugs shape the initial approach to addiction treatment?
Yeah, and I think, in kind of thinking about a topic and what we could talk about here, I think I was thinking of that because I've been thinking a lot about the last 50 years, just because we reached this 50-year milestone recently since the initial declaration of the war on drugs under Nixon. So it's been a kind of a useful exercise for me to say, look, what have we done in the last 50 years? How have we addressed this endemic problem related to addiction in the United States and around the world? How are we addressing it? How has that changed over the last 50 years in light of what's happened in the last 50 years? So I think that's an interesting question for me. And I guess in that context, of course, you can use that as a framework for investigation and analysis and evaluation of our approaches. I think, what is interesting, when you look at what Nixon did really and what the war on drugs was initially about was a concerted effort at the federal level to really focus on these problems of addiction. There was a big fear of returning Vietnam veterans, of course, coming back to the United States, many of whom, if not most, had used opium and opioids in Vietnam as a part
Right.
of. So there was a huge fear, national fear, that we're going to have this massive influx of returning soldiers who would be addicted on the streets of the United States. And this was a big fear at the time. Now, it turned out to not manifest in the way that it was anticipated, but nevertheless, that was a stimulus in part for this focus on addressing addiction. Now, right around the same time, there was the birth of two National Institutes of Health. The National Institute of Alcohol Abuse and Alcoholism, which was founded right prior to 1971 when Nixon declared the war on drugs, which was in 1970. So the National Institute of Alcohol Abuse and Alcoholism was founded in 1970. In 1974, the National Institute of Drug Abuse. So these two national institutes were founded, and those have been very important in terms of the developing story of our knowledge and understanding about the nature of these disorders. Now, we associate, of course, Charles, the rhetoric used by Nixon and the very notion of a war on drugs.
I was gonna exactly ask that question. So great,
yeah.
Yes.
Yeah. So, of course, that notion of a war on drugs and the rhetoric associated with that, of course, implies an identifiable enemy that could be defeated almost in a militaristic fashion. So that was the rhetoric used. And of course, it was a reflection of probably all the war that was going on, in Vietnam and the national dialogue around that, of course. So it was natural, of course, to use that rhetoric and language at that time as well. But what that resulted in was what Nixon described as, drug abuse, quote unquote, drug abuse. It was public enemy number one. And I think, and I often talk about this, I think if you look over the last 50 years, I would argue that we've moved from that rhetoric and that focus and conceptualization of drug abuse being public enemy number one to drug abuse, if you will, being our top public health problem. So that shift in rhetoric reflects, I think, a lot of the knowledge that we've gained around the nature of these problems or conditions or disorders.
So the question, I don't know, but are we still living with the legacy of the war on drugs?
We
and
are.
that mindset.
In part, yes. Now, cultural shifts take a long time to happen. Things happen slowly in terms of the innovation of diffusion of innovation in ideas and policies and effects. That takes a long time for cultures to shift and change, maybe decades, if not centuries, for cultures to change. But of course, there was good intention behind it. There was an idea that this would protect the public. There was an idea that the tough on crime approach would be protective, would have a protective effect. So it was well intentioned. It was just it turned out to be not the optimal way to
Mm.
approach these problems. Um, and
It seems that they would have been better served, perhaps with the benefit of hindsight, of bifurcating the so-called war on the supply side, and where that rhetoric may be a little bit more appropriate because there is a bad guy, there is something we can fight against, but of course on the demand side it's a completely different dynamic.
Exactly. Yeah. And that's a good way to distinguish it. And of course, it is kind of uh, parsed out by that, by with supply and demand. And if we can reduce supply, then that can obviously help with reducing affected persons, because there's less supply in the population. We've seen this notably with fentanyl lately, of course, in the last 20 years, with the increased supply of fentanyl, which is highly lethal, can be highly lethal and kill people at very small amounts given the potency. So again, reducing supply can reduce occasion for harm. But I think what led me to this kind of zooming out over a 50-year perspective, Charles, was the shift and just reflecting on what has changed, as I mentioned. And I think our rhetoric and policy and legislation has changed over this last 50 years. If you think about the kind of legislation that was passed in the 70s and 80s related to this tough on crime approach, the Anti-Drug Abuse Act, for example, in 1986, with its mandatory minimum sentences. There was no discretion. It was just boom. If you were caught with X amount of a drug, you got 5 years or more, and that was it. There was you were just locked up. There was no ifs, ands, or buts about it. So that kind of tough on crime approach, again, was designed to deter. But given the nature of the human mind, it doesn't really serve as an active deterrent. Those kinds of harsh sentencing laws do not deter people, it turns out. And we've learned a lot about that too, but psychologically. So now, alongside, as I mentioned, and the reason why I mentioned the birth of those two National Institutes of Health is because they have produced a lot of new knowledge that we didn't know 50 years ago about the causes of addiction, the nature of addiction, the clinical course, the neurobiology, the etiology, the epidemiology, the phenomenology, the different models of treatment that can work, the clinical course of addiction. All these things have come to light in the last 50 years. And this is why there's been a kind of a new taxonomy, a new understanding, a new classification, a new clarity that's been brought to the nature of these disorders and how it affects the human brain, how the brain is changed as a function of both adaptation to these abnormally high levels of reward and reinforcement that's produced by drugs, as well as the neurotoxic effects in the brain. And this is, of course, these brain changes, of course, is how we to understand addiction. People call it a disease of the brain. You can think of it as a disease of the brain or a disorder of the brain neurocircuitry or an illness or a disorder. It doesn't really matter. The point is that what was once voluntary becomes involuntary. In other words,
Yes.
people are using against their will when they become addicted. So it becomes a compulsion that locomotive is hard to stop. And this is, of course, why it's a psychiatric illness. If it wasn't the case that people were ultimately using against their will, then it would not be a psychiatric illness, because psychiatric illnesses are generally or always categorized and classified as a condition that is out of one's voluntary control.
So if we are looking at this sort of as an evolutionary process going back 50 years, these institutes that came into being to educate the public about some of these issues we're talking about. When have we sort of come? Is there a point where we sort of come into the so-called modern era of thinking about this? When did that actually occur, and where are we today as far as the lowering stigma around some of these things? So, are people starting to understand that the war on drugs is a misnomer and it's a lot more delicate and subtle and complex than that?
Yeah, yeah, I think that's right. That's a good way of thinking about it. It's you could think about it as an evolutionary process that's been revealed and developing over the last 50 years as a result of new knowledge gained. I think there has been some paradigm shifts. I think I wouldn't call it revolutionary, but as opposed to evolutionary, but there have been significant paradigm shifts in our understanding, fueled by our understanding about the nature of these conditions and what can be effective in treating them. And I think, it's been it's been gradual, I would say, for the most part, over these last 50 years in terms of these shifts. Again, punctuated by some of these more dramatic shifts. But I'm thinking mostly about things like methadone for opioid use disorder, for example. That was revolutionary, or arguably revolutionary in the sense that giving someone a longer acting agonist, which essentially is the same drug, same type of drug. It's paradoxical, it's ironic that you give someone the same drug, but it would have a therapeutic effect
Hmm.
as the drug they're addicted to. It's a bit like nicotine replacement. People use nicotine patches to help them stop using nicotine.
Well, but that also is, I guess, a fundamental concept in virology, right?
Yes, right, exactly, yeah. And the notion of inoculation, of course, means you would give some the actual a dead version of the virus,
Right,
and
exactly.
then
So it
the
knows.
body adapts.
Right.
It can create the antibody, and then it can protect against a live virus or live bacteria. Yeah. So it's kind of in medicine throughout the ages, of course, there's been these examples of kind of these ironic, paradoxical approaches, and that's again been one of them. We've seen it now replicated, extended with buprenorphine, with opioid addiction, for example. We've seen it with agonists or partial agonists in the treatment of addiction, tobacco addiction, which has helped people to quit using nicotine patches, for example, just longer acting versions that that can diffuse a steady state of blood availability for the drug, which helps to reduce cravings, which then can allow people, without that nagging craving and compulsion to satisfy that craving, they can then attend to the other kinds of aspects of recovery.
You use the term paradigm shifts. Where are we now? Are we in a particular period, or there are challenges that have surfaced in the last couple of years in this space that you want to talk about or that we need to
Yeah.
think about?
Yeah, I think about it now as I think in the last, say, 10 years. Now, we've talked about this for quite a while. And again, these things take time to come to light, to come to fruition, to manifest in the cultural psyche. But if there's one thing we've learned is that we need to provide and align services and treat addiction as if it were a chronic illness like hypertension or diabetes. Now, the reason why is because we know that these disorders tend to have recurrences. So people will stop for a while, but then there's often a recurrence of the disorder, so they relapse. And this kind of scenario of susceptibility can last up to 5 years or more for people, even after they achieve full remission. So in other words, you get a year sober, but you're not done. Even after a year sober, which is a big deal in and of itself, being able to achieve 1 year of sobriety, of remission from a substance use disorder. But the susceptibility, in other words, the risk of meeting criteria in the following year for the same disorder is elevated relative to the general public, up to about 5 or 6 years. Now, after that time, you're at no greater risk than anybody else in the general public of meeting criteria for the next year for that disorder. But if you think about that 5 year time period, we have most of our treatments are 5 weeks or
Yeah.
at the most, maybe 5 months, and most of our clinical protocols have been tested over 12 weeks. So They've been 12 weeks of a pharmacotherapy or a psychosocial manualized intervention like cognitive behavioral therapy, relapse prevention therapy. And then the therapy ends and you are dismissed, and that's the end of your treatment, typically. There are no standardized, empirically supported protocols beyond those 12 weeks of treatment, typically.
It seems that public sentiment still lags significantly behind, the science, which, as you're saying, has evolved over these last 50 years, last 10 years, and the methodologies that clinicians and so forth, practitioners are using. And I recently had a conversation, another podcast, and we're talking about, well, we've made strides in lowering stigma around mental health, but not so much around addiction. Do you see making strides where they're viewed sort of on par, or at least to the extent that mental health has become less of a stigmatized issue?
Yeah, stigma is when you look at around the world, studies that have been done of stigmatized conditions, it turns out, as you're alluding to, that addiction is bottom of the barrel. It's the lowest element. It's the most stigmatized condition of any condition that is stigmatized around the world in different societies. Now, I think part of the reason for that, of course, and it's even more stigmatized than other mental health conditions. And again, I alluded to this earlier. It is a psychiatric illness, and it's placed in the diagnostic manual of statistical and mental disorders for a reason. Again, because of this notion of compulsivity, turns from impulse to compulse, and results in people using against their will, to the point of their own demise and premature mortality. I think what's helped is, again, understanding about two fundamental aspects which underlie stigma. And one of them is cause, the other one is controllability. So again, stigma is multidimensional. So it's not just about blame and cause, but that's one of the fundamental dimensions of stigma. That drives stigma is if we can say, for example, it's not their fault and they can't help it, stigma tends to go down. If, on the other hand, we say, wait a minute, it is their fault and they can help it, they're just choosing to do it, so they're engaging in willful misconduct at the expense of other people's well-being, then stigma tends to go up. Now, of course, there is elements of choice initially. People are choosing to drink alcohol or use tobacco, or use opioids, or cocaine, or methamphetamine. They choose initially. They're not compelled to use it in the beginning. But what happens, of course, is that we could talk about it as hijacking the brain's neurocircuitry. Some people are genetically predisposed. We know about half the risk for addiction is conferred by genetics. So some of us are more protected right out of the gate. Some of us are more vulnerable, just like other complex illnesses. Knowing that helps. It helps to increase compassion and decrease blame on the cause front. In terms of controllability, that other dimension, we've got two dimensions, cause and controllability. So did you cause it? Is it your fault? And can you help it, right? Can you help it? And again, as I said, it becomes a psychiatric illness because people end up using against their will. And that's the controllability part. And I think that's the neurobiology of addiction, the neuroimaging work that's happened over the last 30 years has, again, helped us understand exactly how the structure and function of the brain is radically affected by chronic exposure to alcohol or other drugs. And these changes in the brain, of course, help us to understand about the nature of the inability to inhibit that impulse.
We talk about stigma. What would you say to the person who said, maybe there ought to be some degree of stigma attached to substance use disorder, that it's not on par with people grappling with mental health issues? People with SUD are less functional, perhaps more inclined toward counterproductive behaviors. And as a society, we need to separate and sanction what we view as productive or counterproductive behaviors. What would you say to that?
But really, addiction really is the classical notion of addiction is this notion of impaired control over the ability to regulate that impulse to use despite harmful consequences. In other words, people using, even to their own destruction and own detriment. Now, not everybody on the spectrum of substance use disorder we have a huge spectrum of substance involvement and impairment that is related to this category of substance use disorder. People at the low end do not exhibit this impaired control over the ability. They may have a little bit of impaired control, but still largely they're able to regulate, but they may be heavy users. They may be on the path to an addictive pattern that where the train leaves the station, and they just, no matter where they put the brakes on it, there's too much momentum behind it. They just can't stop it. So this is part of the problem, is that people at the mild end, and most people who are in the category of a alcohol or other drug disorder, meet criteria at the mild and moderate end, not at the severe end, what we would classically call addiction. So again, this complicates the picture, Charles, in terms of, well, how come people can really control it if they're, again, because we call everybody then with substance use disorder addicted. They're not addicted. Many people are not. Many people are, but that's at the severe end of the spectrum. Actually, that's a minority of people who meet criteria for a substance use disorder. So you can see how it can get misconstrued and complicated when we're trying to communicate these things to the world.
I do want to get into some of your work, the National Center of Youth Prevention and Treatment and Recovery and the Recovery Research Institute, but not before. I just want to make sure we've exhausted this 50-year narrative. Any other thoughts bringing us up to date? Any major takeaways before I ask you about some of the work you're doing?
I think we've covered most of those nuggets. I think the paradigm shifts in terms of, again, I would say that there've been some significant clinical paradigm shifts, of particularly around motivation and the stages of change. We could talk a little bit about that. Again, I don't want to, I know we only have so much time, so I want to make sure we got time for all the things that you want to address. But we could go into depth in any one of those areas. I mean, motivation, I think, is an interesting one in terms of readiness to change, and this notion of being motivated. I mean, I think that was a significant clinical paradigm shift brought about by the stages of change, and which resulted in this notion of a client-centered approaches, or motivational interviewing, which is the therapy that was designed to address ambivalence about change.
So how does that work?
So, for example, if you think about prior to in the 1970s and 80s, most treatment settings would say, look, if you're not motivated, go away and come back when you're motivated. Patient is not ready to change. Come back when you're ready to quit. Now, the majority of people actually are not completely sold on the idea of quitting. So they're ambivalent. About that middle 60% of people actually say, well, you know what? I can see there's some problems here. My wife's telling me that I've got a problem. People are telling me, but I don't, I'm still working. I'm still doing the things I'm doing. So I'm not sure whether I want to quit or not. So the idea here is that instead of saying, well, go away and come back when you're ready, is to say, okay, well, let's talk more about that. What are some of the things you get out of using alcohol or whatever drug you're using? What are some of the things? How does it function for you? How does it help you? And so you sit with the person, you help them work through some of the pros and cons of. So in other words, instead of saying go away, say, no, let's sit and talk about this. Let me see if I can help you resolve some of the ambivalence you have about change. So that was a big paradigm shift, because before that, the predominant model was a psychoanalytic one, where the people had these psychological defenses called denial and minimization and projection. And so these were psychological defenses which came out of the psychodynamic and psychoanalytic school of thought, which were imposed upon and used to explain reason why people did not change addictive behavior, was that they were in denial. And that was a psychological defense. The idea, therefore, was to break down that denial through harsh confrontation. You could break down that through screaming at people, shouting at people, and find a way to get through and penetrate through that. So this was a different approach. Instead of trying to break through the denial, it was helping people to lower their defenses by building trust and therapeutic rapport. So people would feel like it was a safe environment so they could open up and talk about the reasons why they didn't want to change. So it was discovered to be less about psychological defenses, but rather about the appropriate context that could help people lower those defenses, allow some therapeutic endeavor to get in, and then ultimately people could be helped and helped earlier in the process of change before they got into stage 3, stage 4 addiction.
Has technology improved this
Technology.
process?
Well, I think what technology has done is, a couple of things. One is it's allowed people to access services they couldn't access before or couldn't access as readily through telemedicine approaches or teletherapy approaches, particularly access, in terms of rural areas and people traveling long distances to get care. Technology has really helped with that those access points. Number two, it's helped with the portability and accessibility of other kinds of therapeutic technology that can help people through their smartphones, for example. While wherever they are in the world, whatever they're doing, you can have a therapeutic encounter with somebody through the smartphone. You can also using text, using other kinds of media, video chats, or texting and phone calls. And that's enabled therapists, for example, to extend treatment effects and amplify treatment effects for longer periods after initial, maybe face-to-face encounters of treatment.
Have there been any unintended adverse consequences of this technology, of using technology like telehealth platforms or some of these apps that people access?
Well, I don't know if there's been adverse events associated with using that kind of technology. I think.
Well, let me put it differently then. Any caveats?
Well, I think what I was going to say was that, I think there's a question about the relative efficacy of teletherapy, virtual approaches versus in-person approaches. So is one better? Does one, produce a stronger effect, a stronger positive therapeutic effect than the other? And that's a question that we have some clues about, but hasn't really been looked at. Is online, in terms of addiction recovery support services, a common question given, that came out of COVID, where everybody transitioned and it stayed with us, of course, the ability to access online meetings for people utilizing mutual help organization support. Are online meetings as good as in-person meetings? And if so, when and for whom? At what point in the recovery process is it as good or better or worse, and for whom? So there's these kinds of questions, of course, that pertain to the virtual digital world of clinical and recovery support efforts versus in person. Those questions have not been fully fleshed out.
Yeah, and of course, AI is going to present another set of questions as that matures, and it's going to be, if it's not already here. You had mentioned that, talking about consequences, one of the consequences of Nixon's war on drugs, of course, you mentioned these mandatory sentences. How has the balance between criminal justice and public health approaches shifted?
Well, I think I would say that we've come more towards public health and clinical approaches in addressing addiction and away from criminal justice. Not to say that criminal justice approaches have gone away; they have not. And there is, legislation and policy still that is punitive and harshly punitive and doesn't make sense in addressing addiction, but they're still popular because people think that they work as deterrents when they do not. Because the human mind just does not work. It doesn't respond to these distant, variably reinforced deterrents. What it does respond to is immediate, potent, predictable effects. That's what the human brain tends to respond to. So if you look at the legislation, for example, as I mentioned earlier, the Anti-Drug Abuse Act, other legislation that's been passed in terms of harsh, punitive, mandatory minimum sentencing. You contrast that with the later laws, which are generally public health access laws, like the Mental Health Parity and Addiction Equity Act, the Affordable Care Act, which necessitated coverage for substance use disorders and mental health at the same level as other kinds of medical care. So think about that shift at the national level in terms of emphasizing not punitive approaches, but rather clinical and public health approaches.
The opioid crisis. Is there anything we learned, for instance, previous crises